And then we will be going with Steph Klein, who will be talking about the ePraise project manager. And lastly, we'll be going with Reena Lal, who is a deputy EPME pharmacist in Barts Health and NHS Trust. So she will be talking to us about warfarin safety and EPME systems as well. So just a reminder, you will have a questions tab where you can ask questions, and I will do my best to pose these questions to our presenters. In the event that these questions are not asked or we are unable to cover them for time purposes, then we will upload this onto the Medicines Optimization digital page, of which a link I will put in the chat as well. So without further ado, I would like to invite Rachel to start the presentation. Thank you, Rachel.
Thank you, Sangeeta. Can I just double check that you can see me, because it looks like I can't see you now.
Yes, I've just removed my camera. I can see you and I can hear you perfectly. Thank you.
That's great. Thank you. Thanks, everybody. Thanks for letting me come to talk to you today. Next slide, please. Thank you. So we were asked by NHS England to, when it was NHS Digital, when it was NHS Digital, to look at how the new medicines information standards are going to affect patient safety. There's a huge amount of work being done in this area, so our project is quite a small aspect of a massive amount of work, and I'm sure that quite a lot of you are heavily involved in implementing as part of your wider interoperability activities. And so our work was to look at the potential impact on patients and patient safety. So that's just to show you the team of people that are involved. I'm a pharmacist, and Richard Keys is a pharmacist, and Liz and Sean are health economists, and Anthony is our patient co-applicant who works with us on a lot of patient safety work. Next slide, please. So just a bit of background, and I'm sure that most of you are aware of this, that medication errors that transfer between care settings is a World Health Organization priority area. And we all know as pharmacists that the information that the NHS holds about medications and allergies is fragmented often. It's all in different formats, using different vocabulary, it's difficult to share. And the lack of interoperability between care settings can lead to discrepancies that are unintended, or what we refer to in our work as transition medication errors. And this can lead to harm and cost, harm to patients and cost to the NHS. So having sort of digital interoperability means that we can share information about medicines to reduce errors, but also stop the routine of information, but that can improve staff time. We're interested in this work on patient safety, but there are much wider, more disruptive effects of this, hopefully, including quicker discharge, better healthcare planning, and supporting other care processes such as EPS. Next slide, please. So our specific question here was to look at the effect of the IS-DAPB 4113 standard on patient safety. So we had specific questions that we needed to answer, and the first one was what's the incidence of medication errors at key transition? So where are we now before we introduce these standards? And then how much do these errors lead to patient harm, and what does it cost the NHS to manage these errors? And so then to look at whether the introduction of these information standards that will then lead to a more of an electronic information transfer for medicines, how will that improved information transfer impact on the error rate and the associated harm and NHS cost? And we used, this is a desk-based exercise, as you'll see in a minute, and we used published evidence and expert opinion to do this work. So next slide, please. So just to give a very sort of simple framework of our question, we looked at people who were at risk of experiencing transition medication errors. And there are lots of transitions that these interoperability solutions can eventually support. But we focused on 4 transitions where there were some data for us to enable us to actually do some estimation. So you'll see at the bottom the list of transitions that we've excluded. So we focused on admission and discharge from hospital, and then within hospital transitions, and then between hospital transitions. And the intervention was what we refer to as digitally enabled interoperable medicines information transfer, compared with sort of what is going on at the moment. So we assumed that that standard medicines reconciliation was being carried out by a pharmacy professional or somebody equivalent during the inpatient stay. And we the outcomes that we looked at were these errors or discrepancies, unintended discrepancies. Hospitalisation, so if somebody's discharged with an error, then do they lead to does that lead to hospitalisation? Adverse drug events, if somebody's in hospital and they have an unintended discrepancy or error on admission, how does this affect their length of stay? Readmissions comes under hospital, is a type of hospitalisation, and then we also looked at death. So we did assume that all hospitals have EPMA, because that's what the NHS England is aiming for in 2023, across the sort of main part of the inpatient sort of space anyway. And so we didn't look at chart rewrites in our estimates. Next slide, please. So this is just a schematic to show how we did the work. So first of all, we looked at the evidence on how common medication errors were at these transitions. We then did another literature review that looked at what is the patient harm, or the probability of harm, and then the extent of harm, and then the costs associated with managing that harm. And then we looked at how what evidence out there is there if you've already got a standard medicines reconciliation type process in place. What is the effect of making that medicines reconciliation interoperable digitally? So we looked at the evidence around the effective interoperability solutions. And then we used those data to estimate the number of errors in England as a whole across those transitions, the amount of harm, and the cost. And then we took the effectiveness from the interoperability solutions and then modelled or estimated how much the errors, harm and cost would be reduced by the interoperability solutions. And this was done in collaboration with working with a lot of stakeholders and expert opinions. So obviously there's NHS England and the NHS IT leads. I spent time with hospital safety pharmacists. I went into a hospital and had a look at different types of things that they were doing, because my own experience as a hospital pharmacist is a little bit out of date. Talked to prescribers, we talked to different types of suppliers of systems, we talked to patient safety experts, and we spent time talking to patient experts as well. Next slide, please. So this is just a simple summary of the transitions that we looked at. So, and this is the big traffic for transition as well. So where we've got hospital admissions, so you know, so we've got meds rec going on there already, and then discharge, so inpatient prescribing to discharge. And then we also looked at intra-hospital ward and unit transfer, and that was where there was a transfer between a different system. So, for example, if you were going from emergency department to ward, or intensive care unit to ward, for example. And then we also looked at hospital transfers. Next slide, please. So this is a very busy slide, and there is actually a report that's in peer review at the moment, and if anybody wants to ask me any more questions or email me when they can, it's just a summary of sort of what we did. So first of all, looking at the prevalence, or how many errors are there at these 4 transitions in England over sort of a year, we used UK studies where we could and non-UK studies where we had to fill in a few gaps. Fortunately, the English work in this area was actually quite the sort of UK research and patient safety research is probably sort of world leading, I would say. There's some good stuff going on in other countries, but there's a very large critical mass of work going on in this country. And we extrapolated to national estimates, and then we also looked at proportion with potential to cause harm, because obviously, as you know, most medication errors don't actually cause clinical harm. Looking at burden of errors, we looked at if somebody had an error in hospital, what impact did that have in terms of length of stay and risk of death? And then we also looked at if somebody was discharged with an error, how likely was that to then lead to a readmission? So those were the main aspects of harm. It's quite a conservative estimate for harm. And then looking at interoperability on the effect of interoperability, the admission events, we didn't actually find any UK studies that we were able to use. We found a Spanish study that showed that if you had an interoperable intervention after admission, on admission, that reduced your risk of an error. And then also for discharge, it also reduced your error. So we used that to estimate the prevalence of errors after interoperability. Next slide, please. So this diagram, I want you to concentrate on the first column, which talks, and the first column of numbers. So basically, if you look at the number of medication errors on admission to hospital, it's about 15.3%. But once a pharmacy professional, generally in the UK, it's a pharmacy professional, carries out standard medicines reconciliation, you can see that is reduced a lot, to 2%. So then if you then layer on the interoperability capabilities on top of that, you can then reduce the errors further, you can really halve them. And so we carried out the same exercise across these 4 transitions, and you can see that standard medicines reconciliation is already having a big impact, and then interoperability standards, which can only really work in the presence of standard medicines reconciliation, to be fair, they can have a further impact. So these are the numbers that we used in our estimates. Next slide, please. So again, lots of numbers in this slide, so I'd like you to concentrate on the final column. So this is our estimate of, in England, how many medication errors would there be at transitions, at those 4 transitions every year. We estimated about 1.8 million, which translates into about 370,000 patients having at least one error, and of those, about 31,000 having an error that could lead to harm, which led to 36,000 excess bed days, and then 17 million pounds, and about 44 deaths that could be attributed to harm. This is in the presence of, so this is before the interoperability standards and in the presence of standard medicines reconciliation. Next slide, please. So again, just concentrate on the final column, but this looks at the impact of interoperability. If you assume that the information standards are applied to those numbers, so that you can reduce transition errors further over standard medicines reconciliation, then you can reduce the number of errors per year by 713,000. You can reduce the cost of excess bed days by about 6.5 million, and you can reduce the number of deaths by 20. Next slide, please. So obviously there's lots of limitations here. This was an estimation exercise. These data don't exist for us to be able to measure them as routine data nationally. So there is some uncertainty around our estimates. We excluded a lot of transitions. So these are probably conservative estimates of errors, harm and costs. And we're extrapolating from studies to the whole NHS, which obviously, as you know, has its own issues. We also only looked at short-term burden of errors, and we assumed that standards and mechanisms of reconciliation was in place. I think the key message is that, standards mechanisms of reconciliation is a really important part of managing transition medication errors. Is really, really important. But some medication errors will still get through, and improved interoperability from the planned information standards implementation could substantially reduce transition errors and associated harm and cost. We do need better data around how many patients really undergo meds rec and how long after the care transfer this occurs, because admissions, the point at admission seems to be really important. I think that's my last slide. So next slide, please. I think it's just to say thank you very much. And any questions?
Thank you, Rachel. That was really enlightening. Especially the work that you've done is really important to give us an insight of the importance of interoperability in organizations. My question would be, what would the key takeaway message you would provide to our delegates who come from various NHS trusts to share with their colleagues, really, in terms of speaking about the importance of interoperability? What would you say the key takeaway message is for them to share with their colleagues?
So I think I was a hospital pharmacist myself, and I've spent time in some of the hospitals around where I live in the northwest, looking at what's going on. And one thing I was really impressed with is how this is really being driven by pharmacists and pharmacy professionals, and they're putting huge amounts of effort into it. And it must be exhausting given the amounts of other types of work they have to do at the moment. But what I would say is that this is actually the first time I've been working in this area for 20 years, and these information standards and what's going on now is the biggest shift I've seen since I've been working in this area. So it's really exciting. The people who are making the change are doing so much hard work, and they just need to keep going. I really think it's really important. The key message is, first of all, it's clear that medicines reconciliation as it stands in hospitals and discharge planning is really important for patient safety. And so trusts need to keep investing in that because it's so important. And the interoperability standards, again, are really important and will go on. They will improve safety, but what they will do is make the medicines reconciliation and the discharge planning, I'm not going to say easier, but you have better information. And so I think that obviously these interoperability solutions are pointless without the people to do it. So I think my key message is that the people that are this will only work if there are people. Those benefits and reductions in harm will only work if trusts will invest in people to carry out meds rec anyway, but also to then support them in implementing solutions. And I know that every trust has got a different situation. You've got different numbers of EPMA systems in place already. You've got different types of suppliers. You've got different levels of input from the hospital pharmacy department in terms of sorting out the coding. Some of you are using different coding languages. So I know it's an incredibly complex thing that you're working on, but it feels like this is really important, and it's going to be a disruptive technology in a good way, because there's going to be so many things that pharmacists and doctors and nurses and patients that are going to be able to do because they're going to have access to better information.
Brilliant. Thank you very much for that, Rachel. I've just got another question from the delegates, really. So there is a comment to say it's quite scary that interoperability halves the error rate comparing to pharmacists checking, comparing to medicines that pharmacies have checked in intra-hospital transfer. Does it mean we are making 50% human errors when checking hospital transfers? I think it's more of clarification of the data that we've got.
Yeah, so I think what you need to, that's why I presented the 3 levels of numbers, because what you need to see is how much impact the standard MedRec is having. It's massively reducing the amount of errors. And what you're seeing is that some of those errors are still getting through. But I think some of this, human errors, a way of putting it, but I think it's more that if you don't have access to the information, so it may be that the pharmacist doesn't, or the pharmacy professional, or whoever's doing it, doesn't have access to that information. So they're unable to make the correction because they don't know, so I think that's the key issue. Yeah, I mean, it is scary, but then, this is a really complex system. And one of the things that I've realized over working in patient safety and with medicines and errors is that going to 0 errors is possibly, not realistic. And what we're always trying to do is reduce the errors as much as possible and focus on errors with clinical relevance, which is why, you know, one of the speakers today is talking about warfarin, because we know that that's a really risky error. So yeah, I think the numbers aren't supposed to be scary, and I think that the reasons why those errors get through is more complex than just human error. I think it's the fact that you just don't have access to all the information.
Brilliant. Thank you very much, Rachel. There are a few more questions in the chat, but what we'll do is we'll assign them to you, or we'll get a spreadsheet out with the answers as well. Thank you very much for your time today. Really appreciate it. Thank you.
Thank you.
So without further ado, I will be introducing our next speaker. So we have Steph Klein, who is going to be talking to us about ePrescribing risk and safety evaluation tool. So what I'll do is I will invite Steph. I'm just going to check, Steph, as you come on, whether your sound is okay. The floor is yours.
Can you hear me?
Yes, we can hear you.
Can you hear? Sorry, yeah, I have some technical difficulties today, and also I've got some technical difficulties. I've got a bit of a sore throat, courtesy of my kids today. So apologies if I sound slightly gruff. Hi everybody. My name is Stephanie Klein. I'm the project manager for ePrescribing project. I think quite a lot of you have probably heard me speak before, and a lot of you have actually engaged with our tool, so that's great. The plan today is just to run through a bit of a background about the tool for those that haven't heard about it before, and just go through really for those who need more information about what you need to know about the tool if you are going to use it before the sort of the end of the year, and talk a little bit about interpreting some of the outputs that you're getting, just to give a bit more information around that. So we can go for next slide, please. Right, so this project, for those who haven't heard about it before, is very much born out of the fact that ePrescribing is obviously a key enabler to patient safety and improving prescribing, and there's been a real drive over the last few years to get it implemented and to sort of speed up the implementation across the NHS. As we know, everybody has slightly different priorities when they're putting in systems in. You've got variation between vendors, versions, the resources people have to put systems in, and obviously optimization can be impacted on all of those things. So the idea of this project, which is an NHS England sponsored project, was to sort of build a self-assessment tool that would help us collect information about our systems, and we could share learning and try and look for strengths and weaknesses in our systems, or signpost where we can do work to improve and optimize our systems. And this is really what the tool's about. The first version was very, very rough in 2019, which some people might have engaged with. And then this second iteration, I think hopefully is a lot better than the first, has been released in October, and we're trying to sort of like improve the tool and work with yourselves, so we're learning about the tool and how to make the tool better, as well as hopefully users learning about their systems. So the next slide, please. This is just to give a few bullet points about what the project, the sort of outline of the project is. So it was to develop a web-based tool. What it does, it presents a set of fictional patients that you set up in your live or your test prescribing environment, so they mirror the live. Then we'll give you a set of randomized prescribing assessments, and these have all been devised, sort of scenarios devised against known prescribing risks. And those scenarios were built through a Delphi exercise, talking to experts what are the sort of highest risks and extreme risks that face prescribers and patients. And we collated those together and built the patient tests against those. What happens is when you do the tests, you sort of record in the tool how your systems responded to them, and then we collate that information and we provide some assessment reports, and that's what's going to help sort of you see how your system's behaving. And also as a project team, we're going to have a look at all information in an anonymized way to see if we can find particular scenarios or risks that aren't commonly mitigated, or the ones that are mitigated really well. So there's loads of opportunities to learn and signpost improvements. And all of that learning will be coming out hopefully sort of like early next year, when we manage to get all that together. And then the plan thereafter is to do an annual release, so an annual version of this tool that's going to be subject, obviously, to business planning and that type of thing as we go forward into next year. Next slide, please. So this is just the headlines. So that's sort of like what the opening page looks like. We did start in October. With this tool, we only open it for a sort of like a 2 to 3 month period of time, allow people to interact with the tool, and then we close the version. We pull all the data out and then we sort of analyse it together, rather than having something that's available all the time where people could jump in and out, do the test. This sort of like concentrated period allows us to collect all the information together and do really good learning from it, sort of like the chunk of data. So I say it was opened in October and it's going to close on the 31st of December, so at the end of this year. Next slide, please. So this is just to really help people that haven't interacted. As I say, we've had a really good response rate so far. We've got 29 organisations which have gone in and completed the assessment, and that's brilliant. And that's 3 times as many as we had with the first version, so that's really good, and we're really happy to see that. And we do thank everybody that has got involved so far. But for those that haven't, this is just a highlight of what you need people to do. So you register with the tool. That's fairly straightforward. You set up 15 test patients in your system, and then you run 47 prescribing tests against the newly built patients, and then record the observations in the tool. Then you get a sort of like an instant feedback report, and I'm going to go through the report a little bit in a while. And so you've got that information. Unfortunately, because it is quite a new tool and is fairly basic in some terms, we haven't got all the fancy business reporting and sort of exports available in the tool yet. So people, if they want to retain their reports, the personal reports, then they can screen grab them at the moment. But obviously, as we progress, we develop the tool, we'll hope to be able to provide people a lot more, sort of like a better user experience in regard to that. And then I put in there that really once all that's been done, that, you know, we will collect the information and people should look out for that learning early next year. Next slide, please. So important things that people need to note. I have got some FAQs further down, but these are the sort of highlights here. Is that the assessment, if you want to get involved and do it, needs to be completed by the end of the year. It's not very possible to go and have a look and play around with the tool. It only allows people to do one test. Obviously, it's important that, you know, the people are sort of like, you know, they do it once and they do it well. It doesn't have the capability for people to do anything other than that. So sort of like you can look through the user guide, and we've issued the user guide, or it is available at the front end of the tool when you register, just so you can get a feel for what the tool wants you to do before you go in. And also we say that the patient build can be completed separately in different days. We know everybody's busy. We know it's quite a bit time consuming. The patient build probably takes about an hour to 90 minutes to do, depending on how much information your systems allow you to put in. And then the test takes about an hour to 90 minutes. So just sort of think about that. But what we do ask is people complete the first patient build in one session, and then the tool can record and keep the information in a concise way. And then if you want to stop there and then go in and do the test on a separate day, then that's fine. A note there about what we get out of the tool. So you get your report on your risk mitigation in your system, and the information on extreme risks. I'm going to go through this in the next slide, and a breakdown on performance and sort of known error categories. So again, we'll go through that on the next slide. So we could put the next slide, please. So this is sort of like a summary report, a sort of example of a summary report you would get. The first sort of section tells you about your extreme risks. And when we did do the first version, we realised that people want more information, as much information as they can get about the test they performed. And obviously, we've got to balance that with the need to keep the questions, keep the test, the integrity of tests in the right way. So we can't share the scenarios until things completed. But what we do know is that people did fail extreme risks. So I think the example we've got on the screen there is where insulin's been allowed to be prescribed in mils rather than units, and obviously that's something that should be fixed straight away. That's something that should be in all systems. So there's probably only a handful of extreme risks we've got in the scenarios in the tool, but where somebody does fail those, we'll tell you and give you detail on that. In terms of the rest of the report, what you've got is the bulk of the tests are high risk scenarios, and you get a report on how you've done against those. And obviously we can't share the exact details, but we do sort of talk about themes. So we go on to the next slide. So what's available to each individual user is you get a bar chart, and this sort of gives you the themes of where how you're performing in each section. So on this particular mock-up we've got here, the user performed really well and strong in drug allergy and drug duplication, so that's really good. If you looked in the drug lab section where the arrow is, that's red, saying it's not mitigated, but that needs to be balanced with the fact that you know your own system. So if you actually knew that you don't have drug labs connected in your system, and that's not a feature of your current sort of implementation, then you would expect to score badly on that because that's not working. So this is not as much about marking people's homework. This is more about learning about your system and looking at how the tests work with what you know your system is capable of. So I don't want people to be overly concerned or about getting red or not getting less than the scores that they would hope for their system. It's about looking at the results and think about, well, what have I got implemented? Yes, I would expect to see that wasn't mitigated because we haven't built that yet. But other areas where you think actually you should have good good build, are you scoring well in those sections? So it's a very individual report, and it's very much about individual organisations learning about their system. If you go on to the next slide, please. And then what we try to do is add a bit more colour to that. So again, we've got those sort of like classic categories of drug age, drug dose, drug interaction. And on this report, this slide, it tells you how many tests you've actually been given in those categories. So again, if we go down to that where that arrow is, where it says drug lab. Sorry, my earphones dropping out. You can see there that they were given 2 tests, and those 2 tests were mitigated, which is what you expect if your system wasn't connected. So, or if you look in drug dose, they were given 8 tests in that particular category, and they got 1 out of those 8. So that maybe would mean you were more worried. So it's about looking at all the data we're giving you at the moment, working through it, and sort of getting a feel for how your system's performing. Is it as expected or not? And what you can take from that in the themes. And then if you got the next slide, please. And then there's like a pie chart in there, which just gives you another sort of visual summary of how that test's run. Now we do know that there's a lot of variability in how people do tests. And how people are in different stages of the implementation. So this is very much a sort of like a starting point for us in learning about the tool, as well as you learning about your systems and using the tool. And there's some variability in the way in which people do the test, which I can talk about how we're going to try and work that through with people as well later in this presentation. So if we can now move on to the next slide, which I've just put a few FAQs together. These are sort of questions that have been coming up, and I imagine these sort of slides will be circulated after this session anyway, so people will have a look then. So just to pick out a few, a lot of the questions we've had back from users so far is about getting access to that raw data and the scenario details. So that we can't do that at the moment. We can't share that detail because it would just invalidate the tests if those questions were out there. People knew what to expect. But we are talking about the themes, and we will share learning and the themes about the sort of some typical scenarios and pick the sort of like the strengths and the weaknesses of systems out. So that will be coming out in that more general format. I asked a question about suppliers, about the vendors having access. At the moment, we're keeping this within the NHS, but vendors do know we're doing it, and we are doing some work around. And if we do find some particular learning, strengths and weaknesses around systems, again, we'll find a way of sharing that. But that will be part of the programme team to discuss and look at that as the data comes in. Information there about sharing learnings, which I think I've covered, and about the tests and scenarios who's it designed for. So currently, the tool, because it is relatively new, has been based on sort of like typical risks that you find in secondary care organisations, and that's what's focused. But we do know we've had a lot of feedback about having more bespoke tools looking at paediatric chemotherapy, mental health, and those type of things. So that's part of the business planning we're doing for the future. So as the tool improves and get better, and you share with us what you feel you need, we'll be looking at that and trying to business plan around that. See where we can go with that. Next slide, please. And then on the second slide, this is more about the technical issues we've got coming up. Some people are having issues getting access to the domain. I think there was a problem with one of the links in one of the emails. But in general, it should be accessible unless your organisation is not on the NHS network, or you've got particular firewalls in place in your organisations, and you have to log a ticket to try and get around that. But we do have sort of support within the team. So if you email me or you email the support team, they can try and work things through. And then there's that last slide, which is just moved on quickly to. That's just, again, a summary of all the stuff that we've given. And then on the last point I would just like to make is about an opportunity for a post-assessment interview invitation. So we do have Jude Heed, who's a PhD student working with the project team, and she has recently issued emails about follow-up interviews. So for those people who are a bit concerned or want a bit more information about how the test has been done by them and what the results are like, then Jude's happy to do an interview with you and sort of talk those things through, because she's been very much involved in how the scenarios were set up and has been working with us when we built the tool. So there's lots of opportunity for learning there both ways. We're trying to learn from you, and obviously you can sort of learn and from us and how we set things up and what it might mean, how you might interpret results if you need a bit more information there. And I think that's it. Next slide. So yeah, thank you very much for listening, and a big thank you to all of the people who invested time in it and working with the tool. Obviously, the more people we get, the better the data, the better the learning, more information we can get, and then we can share back. So thank you, and I'll take any questions.
Brilliant. Thank you very much, Steph. There's been quite a lot of interest in the chat and also the questions. So just one of the questions is about accessibility. So there have been a few questions about whether it can be accessed outside of the UK, whether it could be used in Wales, and also whether there is a possibility to extend the date, or will there be a future session if they miss the deadline on the 31st of December?
Okay. So it can't be accessed outside the NHS network. We did have a query from Wales, and I think we've put them in the system. But if anybody's got anything particular, if they email yourself, then we can look at individual cases. I don't think it can be accessed abroad. Whether this becomes something larger in the future, who can say? But obviously, there's a lot of interest in, and that's really good. And I think that it could be a really useful tool down the line. What was the last question? Sorry.
And whether there's one of the delegates has said they're going to go live on EPMA in January, so will not have the opportunity to complete this test in December. So will there be an opportunity in the future?
It'll probably be the release next year. It depends when we release next year. But this one we opened it in October, and it was sort of like meant to be closed at the end of November. We've extended that to the end of December, but I think we've got a sort of like a drop dead date of the end of December. So unfortunately, people won't be able to use it after that point until we do the next version. But we might get the next version out more quickly this time. It was just with COVID and everything, things all got pushed back and delayed. But if they want to email me and tell me, that they're interested, and then we can have a look at making sure that they get included in the next round.
Brilliant. Thank you very much. So we will share your email as well. And I think the last one, just very briefly, is asking whether ePraise will provide information on comparing systems so that you can showcase trust doing well in the system and where it needs improvement. Will that be a case in the future?
I think that's obviously something we're working through. It's all about having governance over the information, and at the moment we haven't done the work around sharing information. Obviously, people have got to buy into that. What we'll be looking at currently is just anonymised information. I have inquiries where people want to share their reports with a local trust that they're working with, and that type of thing. And that obviously that's your information. You could share that. That's the users. It's to the user if they want to do that. At the moment, we're not at the stage where we're going to be sort of like comparing performance, specifically named performance of certain trusts or certain product types, but we will try and put the learning together and take that forward. I mean, this is really for the project team to pick up on in January. So we'll give people as much as we can. I think that's a good way of maybe finishing that off.
Thank you. Thank you very much, Steph, for joining us. We'll share your email for anyone who's got any specific queries, and great work with the ePraise tool. Thank you very much.
That's great. Thanks. Thank you. Thanks, everybody.
Thank you. So we've got our last presentation now. So we've got Reena Lal, who's the Deputy EPMA Pharmacist at Barts, and she'll be sharing with us some insights on warfarin safety and EPMA systems. Thank you, Reena.
Thank you, Sangeeta, and thank you for the team for having me on this session today. So I'm Reena, the Deputy Lead EPMA Pharmacist at Barts Health. While we were sharing the screens, I will just be taking my camera off so I can speak to you guys directly. You can see the presentation in full. Next slide, please. Oh, next slide, that's it. Learning objectives. So today I just wanted to highlight issues that we had in our trust around warfarin prescribing electronically, and also to explore solutions used at Barts Health when optimizing the warfarin care plan, and get you guys to think about how you can apply this in your own trust. Just to add in here, we do use Cerner Millennium at Barts Health, and all solutions are relating to Cerner. So if you're using another EPMA system, you may have other solutions that may not have been possible with Cerner. Next slide, please. So in terms of things that we'll be covering today, so we'll just be looking at issues with warfarin prescribing and the solutions that we came up with, implementation, and then lastly ending up with some top tips for trusts who are thinking of optimizing safety around warfarin prescribing. Next slide, please. So why we went about and made the change. So since EPA went live, and we went live in September 2021, we finished rollout in December 2021. We had some data access that we gathered data from September 2021 to April 2022, and in total we have 33 recorded incidences related to warfarin. Now we believe that the issue is actually more common, and the figure that was reported is definitely an underreported one, but we had several incidences reported for warfarin in relation to omitted doses, administration errors, or prescribing delays. We had issues around out-of-hour prescribing, warfarin actually not being prescribed on the weekends, the original care plan, we ran out of orders of the care plan, so there was multiple care plans being used, and it was really confusing when to use what care plan and which order was being used. There's also issues with regards to our omit dose functionality, and it was leading to delays in discharge as well. As well as the data access, we did have a serious incident where warfarin dose wasn't prescribed, was only prescribed as a one-off, and it was not handed over to the weekend team. No bloods were done for the patient. The ward staff didn't actually notice the mistake, and as a result, the patient suffered a stroke. On investigation, one of the conclusions was that the placeholder that we had as part of our care plan was mistaken for a warfarin prescription. So that was one of the things that we really needed to work on when we optimized our care plan going forward. So what we did as a result of all the things that we were seeing, we reviewed and optimized the care plan, and we ensured that it was better aligned to our trust warfarin guidelines, to ensure that all the changes that were being made were aimed to help overcome prescribing difficulties as well as improve patient safety. Next slide, please. So what we had to do, we had to set up an MDT workshop to brainstorm all the issues that we had relating to warfarin, and then come up with workable solutions. So you can see on the far left-hand side some of the issues, and then and on the right-hand side is what we came up with. So the first thing was warfarin daily doses were being missed off. So what we did was we designed our placeholder to actually fire a task as a reminder to nursing staff, doctors, as well as pharmacists to actually check that the warfarin is prescribed and to complete a new power form designed to confirm that they have checked that the warfarin has been prescribed for that day or an admit dose is actually prescribed for that day. What we also found was in our old care plan that the doses of warfarin weren't actually falling off once administered, which caused a lot of confusion. So therefore, when we were revising the care plan, we ensured that we corrected this functionality. The placeholder, as mentioned, found that they served no purpose. Our placeholder was named, this patient is on warfarin and lacked information in it. As mentioned just previously, we now changed it so that it fired a reminder task. But what we also changed was that the information that the placeholder held. So we ensured that the placeholder had information such as target INR, indication, duration of treatment, and any pre-admission doses. And later on in the presentation, I'll show you what our placeholder actually looked like. Our care plans as well, in our initiation and post-initiation care plans especially, there was only one order for warfarin and one omit dose order, which was causing a lot of confusion. So what we've done is change a care plan such that we have a week's worth of warfarin orders as well as a week worth of omit dose orders. So that's an improvement that was made. We also found that there wasn't enough pathology results in our initiation and post-initiation care plans for PTR and INR results, so we made sure that those were added in. In terms of approval processes, once we did the MDT workshop and did the brainstorm, we made sure that all decisions were actually documented and agreed. There were several emails that were sent around to make sure that everyone was happy with the changes that were being made. We tried to ensure as much as possible we had a network agreement. Barts Health is a 5-sided trust, and a lot of the teams sit on different sites, and we had to consult the haematology team as well as the cardiology team. We also consulted our pharmacy governance team, and once we had the right people, we felt we had the right people around that agreed with the changes that were being made. We completed the relevant change forms and submitted this to our trust clinical informatic board for approval. We also then sent all the relevant paperwork to our trust medicine safety committee for comments and approval, so they were happy with all the changes that we were making. Next slide, please. So this is the change of our warfarin placeholder. So firstly, the name was actually changed to something that was more meaningful. So you can see that the placeholder was changed to warfarin dose check. And at the point of prescribing, the yellow fields are fields that are mandatory to be filled out by prescribers. So filling out target INR and what the indication is mandatory fields, and our indication is a drop-down menu that the prescribers can actually select from. You can see here the frequency is actually grayed out, which means that the prescribers aren't able to actually change this. We wanted the placeholder to actually fire a task at 2 o'clock every day. The reason for this is it allows a 4-hour window within what we would assume are normal working hours to actually chase the day team doctors rather than the on-call and overnight doctors with regards to the warfarin dose, so that when this task comes up at 2 o'clock, there's a 4-hour window to actually chase the teams, chase any blood results, check does a warfarin actually need to be omitted or if a dose needs to be prescribed. You can also see here we've got duration of treatment field and a pre-admission dose. So if that information is known, those fields can be filled in, but they're not mandatory. Next slide, please. So if the placeholder is being filled out, this just shows what the drug chart view looked like. So on the drug chart, you can see a task is on the drug chart at 2 o'clock every day, and you can see all the relevant information actually is presented quite nice and clearly on the front end of the drug chart. And the second screenshot you can see at the bottom of the slide is what you can see in our drug chart summary. Again, it's quite clear that the patient is on warfarin, that you need to do a warfarin dose check, and relevant information relating to warfarin is all presented there also. Next slide, please. So I talked about a task firing off to all relevant healthcare professionals. So we have different landing pages for different healthcare professionals. For pharmacists, we have something called a pharmacy care organizer. And in the task column of the kind of electronic handover, if a patient is on warfarin, the warfarin dose check will actually fire in their task column. The same you can see in the doctor's work list. And for nurses, they have a nursing care compass, and under their activities tab, they'll be able to actually have a note to say that warfarin dose checks needs to be completed. Next slide, please. To actually action the task, what you will need to do is go through the drug chart, right click on the drug chart, and then you will see the first screenshot you'll see is a power form, what we call a power form that pops up to actually ask the either nurse, pharmacist or doctor to say, has the appropriate dose been prescribed for today? And there's a drop down menu. You can either select yes, the dose has been prescribed, or no, an appropriate dose has intentionally been omitted. If, however, there's not been a decision, then there's a note here to say the dose is not prescribed. Please do not save the form. You need to actually talk to the team to get either admit dose prescribed or the warfarin dose prescribed. In the second screenshot you can see here is once it's been completed, you will actually see from the drug chart that something's being done about warfarin, and in this instance, yes, the dose is actually being prescribed. And if you right click on that order and look at the order information, you can actually see who completed the form, so there's better governance around who's actually checked whether warfarin is actually prescribed or admitted for the day. Next slide, please. So this slide just shows our warfarin doses post initiation. You can see that we've changed the care plan so that there is 7 orders and they're all set for particular days of the week. And this is a rolling care plan. So if, for example, today is a Wednesday, and if we were to prescribe Wednesdays, Thursdays, Friday, it will be today, tomorrow, and Friday coming, rather than the Thursday kind of gone. So the care plan is clever in that sense. And we made sure that each day of the week, the dose that was scheduled for warfarin was at 6 o'clock in the evening. Just to also mention, for both initiation and post-initiation care plans, we ensured that the INR was actually viewable in the results view when prescribing the warfarin. Next slide, please. So very quickly, there was a lot of stuff done around implementation. There we set a launch date. There was bulletins sent across all MDTs and trust-wide safety bulletins. There was demos done to healthcare professionals, as well as making a YouTube video on end-to-end processes. An announcement was also made on our Millennium. So every time someone logged into Millennium for 2 weeks leading up to the launch, and so 1 week before the launch and 2 weeks after, they knew that there was going to be changes with relation to warfarin. We also pulled a report on usage of warfarin across all trusts, and this was shared again with our nurses and doctors, as well as our pharmacy staff. So when we were launching warfarin, we knew which areas to actually concentrate on. We updated e-learning, user guides, quick reference guides, and made sure that information was available on the Trust Internet, as well as eCoach, which is in our Millennium. And we also added all that material into our email signatures. In terms of launching on the day, EPMA pharmacy team was a point of contact on the launch day, and we made sure that we were based on the site which had the most amount of warfarin prescribed. And on the day, we did walk around teaching sessions. We ensured that we did engage our nursing informatic officers as well as our clinical informatic officers. Next slide, please. I should also mention our next steps for us is, after we do the launch, is to monitor, as well as monitoring datexes, we also have a student who will be conducting an audit at our SBH site to review warfarin prescriptions following on from the warfarin redesign, and to check, so therefore after this changes has taken place, to actually check if doses are still being admitted, or if there's still administration errors or prescribing delays, and we're hoping to do this in the new year. In terms of top tips, if everyone is thinking of doing this for their trust, cross-network engagement is really important across, especially if you have multiple teams involved as well as multiple sites. Junior doctor engagement is really important. Linking in with whoever provides your platform is very important as well. testing, and testing not just within the pharmacy department, but with your doctors as well as your nursing staff, to make sure it works for everybody, and also cascading the information out to the whole of the MDT. Next slide, please. So that's the end of my presentation. Thank you so much for listening. Does anybody have any questions?
Thank you, Rina, for that. That was a lovely presentation and lots of solutions for our listeners to implement in their trust as well. There was a question about whether this the link could be shared on YouTube, the link that you alluded to, that the YouTube link that you used. So that was one question, and I'm afraid because we've run out of time, we can't quite get to any other questions. So I would like to thank you and just wrap up, really, if that's okay.
That's fine.
So, brilliant. Thank you very much, Rina. So I just wanted to thank all of you today for attending our session. You know, today's session was largely around safety within our practices and with our patients. We were able to evaluate, we were able to understand a tool that would evaluate the risk and safety within our e-prescribing systems. We were able to understand the importance of meds interoperability and how it can enhance patient safety. And lastly, we considered the solutions shared by Rina about how we can optimize warfarin care in our EPMA systems as well. So the takeaway message here would be just to say thank you very much for supporting us on our masterclasses. If you have any sort of topics that you'd like us to cover, then please do get in touch. It's a great honor to chair these masterclasses, and I hope all of you have a lovely festive period. And for all of you that are working in the front line of the NHS, I just wanted to send my sincere gratitude to you working in conditions that are currently challenging. But your service is really great and is what makes us great, really. Thank you very much for your time today, and hope you all have a lovely day. Thank you. A very quick reminder as well, the next masterclass is on the 8th of February between 1 and 2 o'clock. And if you would like to access any of the future, any of the previous sessions, please do access it on our Meds Optimization futures page, or alternatively, you can email Sarah Black as well. Thank you very much, everybody.